So I'll be more focusing on the, as a spine surgeon, I'll be more focusing on the clinical applications where we exactly use this technology and how it has changed my practice. So who else knows the importance of weight bearing better than a spine surgeon? So I think most of our spine surgeons, we don't operate any of degenerative pathology of lumbar spine without taking a dynamic X-ray, without taking a standing X-ray. Even for the deformity cases, we always have this weight bearing which is incorporated. But what we see in standard radiographs, weight bearing is the vertebral body's alignment, the amount of translations. But what else we can also see the soft tissue component, which is more revealed when you are actually making the patient to stand and weight bearing the patient. So while you go back to our teachings, whenever you ask for a MRI to be read, our professors always used to ask, put it in anatomical position and then see. So right, left, that's what we are all concerned. But actually we see the MRI in this position, but these are all taken when the patient is like this. This is the actual position where we get the MRIs, but we orient ourselves thinking that this patient is erect and then we start operating on this. So there are limitations, patients are standing but we are operating based on the supine MRI investigations. But many a times this information what we need on standing, we can easily obtain by an X-ray, making the patient stand and do the things. But there are situations where you really need this effect of loading. But what it exactly reveals is the mobility issues and influence of the loading and also gives the patient comfort. But there are some technical limitations. It is difficult to obtain MRIs in standing and movement artifacts. The pain is a component like Dr. Mahajan said, and non-availability of technology is the one major big issue. So, but if you actually see the evolution of MRIs, there are a lot of R&D which has been done in 1.5 Teslas or 3 Teslas, making a superconducting magnet into more powerful magnet, and then expanding into other organs and expanding into peripheral systems. But none of the R&D has been done on load bearing or kinetic part of the MRI, which is, as a spine surgeon, we need to have that information. But there are some attempts to do that by applying a external device, like what you call it, it's a Dyna vest, where there is a MR compatible compression device. It's like a vest attached to the chest, and then there is a foot plate. We try to apply the compression during the inside the MRI gantry to reveal what exactly happens when the patient is in supine position. But now these different technologies of load bearing MRIs have come up, which can have a potential to be taken sitting and standing and in the movement as well. And SOT has come up with these things which can make the patient quite comfortable, and metal artifact reduction, and even can take it faster. The issue with the previous weight bearing MRIs is they are slow and your resolution is not so good, but this has been improved. But coming to exactly as a spine surgeons, where we need this information, when the symptoms are out of proportion, you see the patient is clinically symptomatic, but you can't document anything in MRI, and there is no clinico-radiological mismatch. You see a big disc at L4-5, but the patient also complains anterior thigh pain. So you are confused. So what exactly is happening? And there are some issues where you want to have occult lesions which will be revealed. And also post-op spine is the one big area where you want to really know the effect of loading on the spine. So because Mahajan sir has actually put a lot of information on the lumbar, so I try to focus on the cervical, where we found it very interesting things are happening in the cervical spine. So cervical can be easily acquired and also faster because they have a dedicated dynamic cervical coil. So this is how we take cervical MRIs. We'll make the patient comfortably sitting, and I can also take MRI in the neck flexion and extension. And this is how the machine rotates. We make the patient comfortably sitting, and then the machine actually rotates. Or you can also do the reverse way. We can make the patient gantry standing and then keep the patient inside. And inside the machine, the patient can have a flexion and extension, and you can see the effect of loading on the spine. So, and also can have a kinetic examination, which is an option, but as of now, I didn't find very good reason to do these things in a clinical perspective. But this is one of the few important things which this patient has got supine with significant radiculopathy not resolving to conservative treatment, but we subject the patient into sitting, then we can identify the reason for the pain and you can suggest some up treatment for this kind of patient population. Now, our management entirely depends on the MRI. If you see, these are the, especially in the cervical myelopathy patients, there are 4 series of MRI. The first patient, maybe you can try conservative, and the second patient, you need posterior, you can need anterior and combined. But actually, see, all these MRIs were taken in a single patient in different positions. So what happens exactly is this: the first one is in the supine, second in the sitting neutral, and sitting flexion and sitting extension. There are a lot of things which are revealed, especially from the posterior longitudinal ligament and the ligamentum flavum, which are revealed when the patient is actually sitting. So we have one of the difficult cases. This patient has been presented to us with typical myelopathy and has been consulting a lot of doctors for the past 2 years, and is worsening in terms of radiological, neurologically. But his MRI shows subtle changes of signal at 3-4 level. But none of the surgeons are able to identify that this could be the reason, and our surgery is going to improve the patient. And this has been treated as a medical myelopathy and has been referred to neurophysicians. But actually, if you subject this patient into sitting MRI, now exactly see where exactly the compression is happening. So exactly at the area of signal intensity change, you see significant compression happening at the 3-4 level. And now you are convinced, and then you can operate on these patients. So similarly, the behavior of the compression can also be treated, can also be known with sitting in flexion and extension. But those are the patients with the signal changes with progressive myelopathy. You can see how it behaves, and you can identify the exact reason where there is a compression, and then you can suggest the treatment accordingly. When the symptoms are out of proportion, this is an interesting case which we have come across. This patient has got a significant myelopathy and rapidly worsening, but MRI supine, taken in the supine doesn't suggest any major compression. But if you subject the same patient by just sitting, you can see the significant amount of compression which is happening at 3-4 level. But somehow it is interesting for us to know that a lot of these patients are happening, these compressions are happening at 3-4 level. So usually we think the C6, 5-6 is the worst area where there is a lot of body weight which falls on, but dynamic effects are happening more at C3-4, and we have been consistently seeing in 3-4 level in these patients. The flexion doesn't show, again, flexion doesn't show any compression, and if you subject the patient to extension, there is a pincer grip effect which is happening at the 3-4 level. So you can see from the sitting neutral, supine neutral to sitting extension, there is a significant change, and so you are convinced with the thing. So this also had led us to good research on this, and we are happy to say this information presented at SRS, and we won the SRS White Cloud Award for this. And also in the selecting approach, so if you see the patient MRI, the first MRI in the supine, so you might be tempted to do 2-level ACDF, 2-level anterior fusion, but the extension, sitting extension, you are convinced that there is a multi-level disease. You may need to address all the levels, especially when the patient is myelopathic. There is no radicular pain, so the myelopathic, then you might operate on these patients and all the levels. And also post-laminectomy patient. This patient has underwent a cervical laminectomy 7-8 years back, and then now presented with worsening of neurological status and again developing myelopathy. So we subjected him to dynamic MRI, then we are able to notice the instability, exactly where it's happening, and the same thing is reflected during the surgery where we expose the lateral mass. There is a frank instability happening at 3-4 level, and the spine is completely unstable, and which is causing the myelopathy post-laminectomy scenario. So these are the things which we are not very aware of in our regular practice. We tend to treat this patient, and because myelopathy, we can only arrest your symptoms, we can't guarantee the progression of the symptoms. Those things we used to discuss, but this patient had got a significant instability, and you are actually the facets are subluxed, and you are actually able to pass a pen field into the facet, and there is a completely mobile spine. So we just stabilized this patient. I had done wonderfully well post-operatively. So coming to the issues for minimally invasive surgery in the lumbar spine, this is one other area where we found out this is useful. So now this era of doing a indirect decompression, we had a just wonderful symposium of Cambin's procedure, K-lift procedure in the morning. Similarly, O-lift and ATPs are being done nowadays by just doing a indirect decompression of the anterior one. So the problem with indirect decompression is we don't know what happens when the patient is standing. We don't know what happens when you do a indirect decompression. What we have is only the supine MRI. So this is the supine MRI of the patient. When the patient is actually standing, you can see the significant amount of compression happening here. So we subject these patients into traction MRI. So we use the traction, regular lumbar traction onto the waist side, and you can see the decompression of the canal happening nicely in these patients. So this is supine, and there is standing compression, and then traction. Traction is akin to indirect decompression because it works on the principle of indirect decompression. So this is one of the case where we have done a O-lift. You can see the amount of decompression exactly similar post-operatively with the O-lift. So this can give you some idea whether this patient is going to be successful with the indirect decompression or not. Similarly, in the patient we had done the oblique lateral lumbar fusion transcambin procedure. Okay, see that the amount of compression in the supine and then standing and the traction, see the amount of decompression happening in the post-op, which can be, so we could predict what is going to happen to this patient by applying a traction. Maybe this technology can also be used in a supine regular 1.5 Tesla as well, if you can have a some radiolucent material adapted doing it in the regular setting. And this also gave us opportunities to win the EVO Spine's Discovery and Innovation Award for that year. And one of the, even this technology we have started using into the basic science research. So where I think we are involved into measuring the disc diffusion. We had done a lot of studies on the disc diffusion with my mentor Dr. Rajshekaran, and we won the Easels Prize in 2004 for studying the amount, how the disc gets the nutrition in the spine. But this was done when the patient is in supine position. But disc nutrition can happen in two ways. One is by diffusion, another one is by convection. The diffusion is something which happens as a concentration gradient. If there is more solutes outside and less solutes inside, they just diffuse. This is a passive transport, and small molecules diffuse through that process. But there is a convection also, where exactly there is a pressure gradient. Like once you apply the pressure, then the solutes will pump into the disc. That's there's a load-based things, and the large molecules will go through that process. There's glycosaminoglycans, growth hormones, proteins, enzymes. Those things get diffused into the disc by applying the load. So the problem is how to apply the load in MRI. So and how to study these things in the MRI. There were attempts to do in the rabbits by applying a external compression device on the spine, and then they started compressing the spine and studying the amount of nutrition. And there is also people have started doing it in a DynaVest, which is an external applicator, and compressing the spine and doing it. But we use this technology to study the amount of disc diffusion, what happens to the spine of the patient, making the scan in the supine position, and also we make the patient in supine, in the standing, and also in last 30 seconds, I think. I'll just finish off. So this is how we get scans in supine position, standing position, and again immediately we make the patient into recovery. And we started taking these MRIs in the pre-contrast 2 hours, 6 hours, 12 hours, and 24 hours, just to see how the dye is going inside and coming, is there anything is leaking outside the disc. So we found very interesting things. I think this is the first time in the literature somebody has proved what actually happens when you're naturally standing and taking resting. Standing acutely squeezed out the average of 26% of small molecules from the center of the nucleus pulposus. They actually squeeze out of the disc when the patient is standing. But immediate post-standing recovery, there is sucking in of all the solutes which has leaked out up to 104%. There is a enhanced recovery which is happening. The dynamic movement of supine to standing to resting, the movement actually caused more solutes going into the disc and getting pumped in. So that's in supine position where the solutes are going in. In standing, there is something leaking out, and then recovery, there is a lot of nutrients coming back into the disc. And so we are happy to say this has won the Easels Prize for this year's for doing a for biomechanical and clinical science category. So to conclude, weight bearing has a lot of potential, especially this machine is a gadget. The indications have to come from the surgeons, not from the radiologist, I guess, because they can do whatever you ask them to do, but where you exactly need is something which we need to develop. We are still evolving and trying to see where exactly we can use these things. But so far, this has been giving a good clinical insight, especially in the cervical spine where there is a myelopathy patients. This is a wonderful tool to be used in. Thank you very much for your kind attention.